and welcome very much. I'm so grateful that you've been able to attend today for today's Tuesday topic, critical illness, adrenal insufficiency, and our consideration in the ICU population. So I'm going to start off with a 50-year-old woman who's found unresponsive in acute shock and with severe hypotension tachycardia. Hours after an elective surgery, she had a nephrectomy for an extensive upper pole renal cell carcinoma. Her chemistry reveals that she is severely and profoundly hyponatremic and hyperkalemic. That's always a really big clue, and that's something that we should be always paying attention to. And relatively low glucose, 81 milligrams per deciliter. In a person who's in acute shock, we never expect to see hypoglycemia unless we see liver failure. She gets transferred to the ICU from the med-surg unit for hemodynamic management. She gets volume, she gets vasopressors. She's intubated and placed on invasive mechanical ventilation. But in the review of her medical history, we see that she has had a 3-month history of lethargy, fatigue, a decrease in her appetite, and unintentional weight loss that actually just started kind of rapidly occurring in the middle of this 3-month period. And she's had some subtle complaints where she's actually presented herself to her primary care physician with just nausea and pain in her abdomen, joints, and muscles. And she kind of attributed it to arthritis. That's what she talked about. That's kind of what the provider said as well. Then we're going to look at case. So what do you think about this? Is this a person who has adrenal insufficiency? And if so, is it pre-existing, acute, or chronic critical illness? Now, you might not even know the difference between those three, and that's okay. That's why you're on the call, right? So you want to think about this as you look at this. Is this a patient who has a pre-existing disorder? Is this an acute disorder, or is this a chronic disorder? Then we look at case number 2, and we're going to ask the same kinds of questions. This is a 55-year-old man who's brought into the ED in respiratory distress, very unstable, altered mental status, and high-grade fever. So immediately, of course, our assumption, and we would be correct, is that he has septic shock, and our approach to him is that we believe it's due to community-acquired pneumonia. He's intubated, ventilated because of his respiratory failure. But despite adequate fluid resuscitation and high-dose vasopressor therapy, he has persistently low blood pressure. Okay, now this is in his first day. He's so acute. But does he have a pre-existing adrenal disorder? Does he have an acute adrenal insufficiency? Or does he have what we call a chronic critical care or critical care related adrenal insufficiency? So there really are 3 things that we have to think about. We're talking about adrenal function, we're talking about critically ill patients, and how we're going to evaluate them. And then the last case is a prolonged critically ill 67-year-old man who was admitted to the ICU quite a long time ago. He's on day 30 as we end this case study. He was admitted to the ICU for abdominal sepsis due to a bowel perf, and he required several redo laparotomies. He had an abdomen that was eventually left open because they weren't able to close it because of the edema. And ICU day 30 remains encephalopathic and dependent on vasopressors, mechanical ventilation, and renal replacement therapy. Now, this is on day 30 in the ICU. Now, a lot of times we don't see patients like that necessarily in a cardiovascular ICU, but we see them a lot in medical ICU and a fair amount in a surgical or trauma surgical ICU. So again, what do you think? Pre-existing, acute, or chronic? So just really a quick overview and review of our hormone pathways. And really the only hormone we're looking at today is the adrenal hormones, right? So remember that the pituitary, under the control of the hypothalamus is what responds to this significant stressors. So when you have hyperinflammation, you have a surgery, you have a trauma, you have acute hyperglycemia or acute hypoglycemia, these are all, and blood pressure changes, these are all stressors. They stimulate the hypothalamus, the thalamus communicates to the pituitary, and the pituitary releases its activating or stimulating hormones. The hormone we're looking at today is the hormone that gets released from the pituitary gland under hypothalamus control. The pituitary gland releases adrenocorticotropin hormone, ACTH. That ACTH acts on the adrenal glands, and that stimulates your adrenal glands to actually release both cortisol and aldosterone. We're really focusing on cortisol right now, but aldosterone is also very important. And cortisol, of course, is going to significantly and profoundly impact your cellular glucose. It also significantly, profoundly impacts the uptake of the neurotransmitters, epinephrine and norepinephrine, which are released from the adrenal medulla. So, by the way, without good adrenal function, your patient cannot survive shock. Your patient will not survive sepsis without adequate adrenal function, because the cortisol in conjunction with the aldosterone and the significant then correlated response of available glucose for cellular metabolism, the release of epinephrine and norepinephrine actually assist your patient in maintaining his mean arterial pressure, maintaining his normal metabolic function, maintaining his normal cellular glucose. Now, most of the time when we have somebody with refractory hypotension, maybe now you do that because you've listened to me a lot, or maybe you read a lot of evidence, or you're working with a physician who reads a lot of evidence. But most of the time, we're not thinking about this when we have a patient with refractory hypotension in acute critical illness. And we are not thinking about it in chronic patients who we just cannot get them off their vasopressor. It might not be high dose, might be low dose, but you just can't get them off their vasopressor. You just can't wean them from the ventilator, and they continuously need other organ supports like CRRT. Those are more chronic patients. And those are the two groups we're really concerned with. We're not necessarily concerned about somebody who has adrenal insufficiency, primary adrenal insufficiency, who has hypoaldosteronism or gigantism or some other kinds of primary issues when they first present to us, because we should know that already from their history. People don't really survive well if they have primary adrenal insufficiency and they've not been treated. But it is really important to appreciate that people who have primary adrenal insufficiency, who learn about their illness, when they get dizzy or lightheaded, they inject themselves with corticosteroids. They also inject themselves with epinephrine, and they come to the emergency room and they have a badge, they have a band, they have a necklace, they have a family member. It's everywhere in their chart. And the only thing that will save their life is corticosteroids. So we've really got to pay attention to this when we're talking about critically ill patients and how we're managing them. But what I really want to think about is, in addition to that primary adrenal insufficiency, which is life-threatening, but we should know about the patient that they have primary adrenal insufficiency, are the patients who actually exhibit acute or chronic adrenal insufficiency related to their disease state, and how we should be suspecting them and thinking about them. So really important to appreciate that we're talking about three basic organs, in endocrine organs in communication. The first one is the hypothalamus, the second one is the pituitary, and the third one is the adrenal gland. Now, hypothalamic and pituitary function are relatively preserved in a shock state that's not ongoing, because you have redirected blood flow to the brain, and typically you can preserve most of that function. I'm not talking about people with strokes or head injuries or basilar bleeds that have hypothalamic pituitary involvement. I'm just talking about your standard critically ill patient. As long as they're preserving blood flow to the brain, hopefully you'll have maintained a basic hypothalamic pituitary function. But if you have altered blood flow to the adrenal glands, you may actually have some adrenal infarct and adrenal dysfunction. And it's really important that we appreciate these three organs, hypothalamus, pituitary, and adrenal gland, in the operation of the release of cortisol, aldosterone, norepinephrine, and epinephrine. Really, really important. When you're looking at this, what you're seeing is hypothalamus releases what's called corticotropin releasing factor. That actually activates the pituitary to release adrenocorticotropin hormone, which then in turn stimulates the adrenal gland to release cortisol and aldosterone. And your physiologic effects is that the cells respond to that, and then in a negative feedback mechanism, meaning we solve the problem, thank you very much, now shut off this hypothalamic control, shut off the pituitary hormone release, and that causes a reduction in the adrenal hormone release. So really, really important for us to appreciate this and also to have a good index of suspicion when we're talking about people who have liver failure, renal failure, or cerebral dysfunction, that we're going to have some suspicion about this in these patients when we're evaluating them. Okay, so very simply, of course, adrenal glands are located on the top of each kidney, and they're divided into the adrenal medulla and the adrenal cortex. And as I've already said, the adrenal medulla secretes epinephrine and norepinephrine, and the adrenal cortex secretes aldosterone and cortisol. Now, all of these, epinephrine, norepinephrine, aldosterone, and cortisol, are what prepare the host, the human body, to survive a physiologic stress response. So let's remember, I'm not talking about somebody who comes into you, a female with a beard or a buffalo hump or really patchy hard skin. I'm talking about somebody who is under your care, who has had shock, and in particular sepsis, which seems to be the most significant in terms of actually deregulating this hypothalamic pituitary adrenal gland triad. Very important that you are always considering with an index of suspicion and something that you have to revisit every day. So maybe you asked on day 2 of caring for a patient who has refractory hypotension on high-dose vasopressor, and that resident or that attending or that APP said, no, I don't think that's what the matter is. But you come back on day 2 and the patient is worse, you need to ask the question again, could this be a form of adrenal insufficiency? Not pre-existing, but critical care. And what can we do about it? And how do we evaluate our patient? So really important to look at what it is the adrenal gland releases. Epinephrine, norepinephrine, aldosterone, which regulates potassium and sodium, and cortisol, which helps us to regulate vascular tone and our glucose release and glucose uptake. So really, really important when we're talking about these glands and these hormones. So again, I just want to remind you, hypothalamus releases corticotropin hormone, that's the CRH, that stimulates the pituitary gland to release ACTH. ACTH actually stimulates the adrenal glands to release primarily cortisol, but also aldosterone, and our other stress hormones, which are affected by this as well. And you can see that the kinds of stressors that create this are under your care. People who have refractory hypotension, who have high fever, who have traumatic injury, surgical injury, same thing, it's a trauma, it's just controlled, or persistent hypoglycemia, like your patient's glucose is low and you can't figure out why. You feed them, it goes up a little and then it drops again, and they have actually a relative hypoglycemia. You should be always considering that this has something to do with the adrenal glands. Now, you want to remember that the pituitary gland is a releaser of vasopressin. Hypothalamus creates vasopressin, pituitary gland releases vasopressin, but vasopressin also has an effect on the release of adrenocorticotropin hormone. And that's going to be very important when we talk about our parade of vasopressin vials that is persistent in every critical patient with hypotension. Everyone is on vasopressin, and vasopressin can induce some pituitary dysfunction. Now, that's a secondary problem with the utilization of vasopressin. And if you're giving vasopressin, you're not really worrying about the pituitary gland's release of vasopressin. But what you do need to think about is the pituitary's release of adrenocorticotropin hormone. The other stimulus to the pituitary, so that goes directly to the pituitary outside of the hypothalamus, is the presence of pro-inflammatory cytokines, which are highly present in patients who have severe sepsis. So, beautiful summary published in 2022, and I'll have the reference in just a second, is an intrinsic failure insufficiency of any of those 3 organs with the HPA axis, hypothalamus, pituitary, adrenal, HPA axis, followed by a secondary stressful insult, leads to a really quick clinical deterioration. That patient needs intensive care and early dosing of hydrocortisone. So that means not day 3, day 4, day 5, when you're at 100 or 125 or 150 of norepinephrine and 20 of epinephrine, and you're on vasopressin of 0.04 mics, it means within that first 12 hours, by that second 12 hours, you should be considering whether or not this patient would benefit from dosing with hydrocortisone. Now, we now know that you need to use hydrocortisone, not Decadron, hydrocortisone, cortisol, plus you should be considering fludrocortisone, which actually regulates the aldosterone as well, that you have to consider those two together. Now, in most critical care practices, we don't typically give cortisol without also giving fludrocortisone. So those two things are given together, not necessarily at the same time, but your patient should be receiving both of them every day if you're trying to evaluate whether they have adrenal insufficiency and whether the replacement of those hormones can actually improve their outcome. Now, I'm going to say, as a bedside nurse, there are three major keys here. Number one is refractory hypotension. So you're on 8 of norepi or 12 of norepi and you're still going up, this is refractory hypotension. If you're going to 20 of norepinephrine, you're now adding epinephrine, your patient is still hypotensive, this is refractory. Don't allow this to persist for days without a discussion about whether or not this patient might improve if we were to give steroids. And there's a lot of caveats to that, and we're going to cover those as well. So number one, refractory hypotension. In your intensive care unit, with your providers, you should have a written, protocolized definition for what refractory hypotension is. That isn't determined by an individual physician. Refractory hypotension should be defined. In your unit, it might be 3 times the starting dose of norepinephrine. Norepinephrine at 20. But, like if your order set says you can titrate to 150, your patient has refractory hypotension, and you've spent 130 micrograms of norepinephrine when you already knew the patient had refractory hypotension. So I'm not saying you're not going to still do that. You just need to do that more intellectually. You have to really discuss why this patient has refractory hypotension, not just feel powerful that you can titrate upwards trying to get that mean arterial pressure up, but really asking why it is that you're having to titrate so high. Okay, second point, relative hypoglycemia. Now, relative hypoglycemia means that in critical illness, and in particular, if you are using number one, epinephrine, and number two, norepinephrine. When I say number one and number two, I mean most significant effect on insulin resistance occurs with epinephrine. And then you have a secondary effect. It's not quite as profound with norepinephrine. So you're a critically ill patient, you're on 12 of norepi and 5 of epi, and your glucose is 110, 120, 140. That's a relative hypoglycemia. If I'm using epinephrine and norepinephrine, I'm expecting that your glucose levels are higher, probably high enough for you to need insulin until I titrate those vasopressors off. So refractory hypotension, relative hypoglycemia. And then the third one, which is a very good signal of the failure of aldosterone. Aldosterone works to keep your potassium and sodium in normal balance, okay? So what that means is when you have effective aldosterone, your sodium and potassium may be normal and balanced. They might be low, both low, but balanced. They might both be high and balanced. But if your potassium is high and your sodium is low, you should always consider or suspect that that is a form of adrenal medullary failure, of adrenocortical failure and aldosterone insufficiency. Now, lots of times with patients who are hyperglycemic, you'll see they have a high potassium and a low sodium. But as you give them insulin, you'll see the sodium will start to rise and the potassium will start to drop. So if your patient had a relative hyperglycemia, you start on insulin, your expectation is as the glucose comes down, the potassium comes down, and the sodium comes up. That's a normal response to insulin. But if I have a patient who is not hyperglycemic, who has a high potassium and a low sodium, and they are critically ill, and they have refractory hypotension and or relative hypoglycemia, that again is one of what I consider a bedside nurse's trio for actually asking whether or not we should be giving both cortisol and fludrocortisone. That's an aldactone stimulant. Okay, so a mineral corticoid, actually, I was better to say it that way. A mineral corticoid. So a glucocorticoid and a mineral corticoid. And those need to be given together, not at the same time, but for the same patient every day. They should be getting that. If these are the three things that you're seeing. This to me seems pretty darn straightforward, my friends, and it probably relates to 50% of the patients that you see in an ICU setting, where when they're really sick and you're titrating up and you're titrating up and you're trying to figure out what's going on, and you keep titrating up, but their blood pressure doesn't respond. And if they're not requiring insulin, you should be saying, what the heck is going on here? Because they should be hyperglycemic. They're on high dose norepi, they're on high dose epi, they're not hyperglycemic, something is wrong. That's why it's a relative hypoglycemia. Okay, so we just want to remind ourselves, glucocorticoid, the main one is cortisol. First and foremost, it increases my blood glucose levels. And particularly when you're talking about physiologic stress, as we release cortisol, our blood glucose levels go up. That's in order to provide more glucose for the hypermetabolic cell. Now, of course, that's got to be balanced by insulin for insulin transport, but still, you're going to look at that significantly. You're also going to look at the effect of the mineral corticoid. The mineral corticoid affects that sodium and water and salt and sodium and potassium balancing. And of course, cortisol really aids us in coping with our physiologic stress. And then when we think about aldosterone, also affects sodium and water balance, fluid and electrolytes, but actually remember, it balances sodium for potassium. They're both salts, but it balances sodium for potassium. And aldosterone is under the control of the renin-angiotensin-aldosterone, or ROS system. So remember, when the blood flow to your kidney goes down, you increase the release of renin, which then is converted to angiotensin and angiotensin 1 and then 2, and that stimulates aldosterone release. So as you release aldosterone, you should be retaining more sodium and more water, and you should be releasing some potassium in exchange. That's the normal relationship. So we just want to remind ourselves that we have a lot to think about when we're at the bedside of a critically ill patient. Now, current evidence says to us, if you have a septic shock patient who's refractory to vasopressors, so they're on norepinephrine at 20 to 30 micrograms, and there's no other cause found, you've fluid resuscitated, you should always give hydrocortisone. And that's usually given 200 to 300 milligrams IV per day. Now, you might first give them a bolus of 100 milligrams and evaluate over the next 2 hours their response. And if they respond, then you put them on a 200 to 300 milligram IV per day. That could be divided into four, the total 300 a day divided into 4 different times or 6 different times, or you might even hang a drip that administers 200 to 300 milligrams IV daily for septic shock patients. And in general, this is the consensus today, that we should be giving hydrocortisone for septic shock patients who have refractory hypotension if there is no other cause found, meaning you don't have a spinal cord injury, you don't have anaphylaxis, you have septic shock. You might have cardiac shock too, but you're still going to give hydrocortisone. 200 to 300 milligrams IV daily, and you can give that in 4 divided doses, 6 divided doses, or a continuous drip for 24 hours. And of course, any patient that you care for who has pre-existing adrenal insufficiency. So you know that from their history, like our first patient, you could kind of tell she was adrenally insufficient. She had a lot of problems that were associated with adrenal insufficiency. So if they have a specific indication for corticosteroids and they go into shock, they must be on steroid replacement. What we shouldn't do is we just don't give everybody corticosteroids. Because you have sepsis, you don't get steroids. You get steroids because in sepsis, you are refractory to norepinephrine and or epinephrine. And unfortunately, what we see, and we keep repeating studies after studies, and every study gives us some different types of results, is that actually, in general, the administration of corticosteroids in these patients who have refractory hypotension and or refractory or relative hypoglycemia and an imbalance of sodium and potassium. You don't have to have all three. The most important one is refractory hypotension. That's the one that really drives your practice. You don't need to have all three, but you can have all three. It doesn't show a statistically significant reduction in mortality, but it does show a reduction in the duration of septic shock, which means other things that occur during the time period that your patient has septic shock that are not fixed by the administration of steroids also need to be addressed. This is not going to fix everything. This just replaces the hormone that you might actually need in this critically illness state. The other thing that's really important is there is no evidence whatsoever, no support anywhere in the literature that says you should be doing ACTH testing. That means you're giving corticotropin stimulation hormone, measuring the response of the cortisol, because nobody knows what the response should be. Nobody knows what the level should be for you to survive. And utilizing ACTH stimulation means that you are delaying therapy while you're making a diagnosis that you can already make from the clinical signs. Now, you're working with a fantastic critical care provider, and they insist that you do an ACTH stimulation test. Are they doing that because they want to understand whether the patient has a primary or secondary adrenal insufficiency? You should ask that question. Or is it just to see what the patient's circulating steroid levels are? If all we're trying to do is figuring out what the circulating cortisol levels are, by the way, this is not going to help us make that diagnosis. So it's, unfortunately, different people read different evidence. They believe in different things. And we just have to be aware of what the evidence shows. We're not the ones making the final decision. And all that worries me is if you're delaying for a test, you are delaying therapy, which could actually be possibly life-saving. So when should you really consider this and advocate for your patients? So shock and refractory hypotension, severe hypotension, out of proportion to the severity of illness. If the patient was complaining of abdominal pain or so-called abdominal pain, if they have relative hypoglycemia, refractory hypotension, unexplained fever, low sodium, high potassium, a high BUN, high calcium, not all, they don't have to have all, but they have any of those, which almost every one of your patient does, or eosinophilia. These are all related to acute adrenal insufficiency. And then, of course, you have to think about other kinds of patients who come to you who are already hypothyroid. They are almost always adrenally insufficient. Or they have gonadal failure. They are almost always adrenally insufficient. That's really pre-existing adrenal insufficiency, but it is something for us to think about. But again, unexplained hyponatremia and hyperkalemia in the setting of hypotension unresponsive to catecholamines, they should get 100 milligrams of hydrocortisone immediately. Immediately. Okay, so that means it's 6 hours after you've taken over the care of that patient. They've just been on your unit for 6 hours. Maybe they were in the ED for 4 and they were getting high-dose vasopressor therapy, and they come to you, and on the first labs, you see sodium is low and potassium is high, and they are unresponsive to your norepinephrine and epinephrine. They should receive 100 milligrams of hydrocortisone right away. So that should be your discussion. You don't write the prescription. I understand that. I'm not trying to make you into doctors or APPs. I am trying to say to you, you are responsible for actually bringing the context of these situations to your providers and asking the question. If they say no, you've done your due diligence. But if you don't even bring that to that trio, hyponatremia, hyperkalemia, and refractory hypotension, and remember, refractory, meaning that you're on catecholamines that you have titrated and they're fluid resuscitated, I feel that that's negligent. because I feel you have a responsibility to report these vitals and to report the lab values in the setting in which you are clinically operating. And a lot of times you're titrating up on vasopressors and your providers don't actually know that they wrote an order for you to start at 4 and you are now at 40. They don't always know that. But the responsibility for you is to make sure they know that you've increased that vasopressor because the patient has refractory hypotension. Because your order sets say titrate up to 150 for hypotension to get the MAP above 65, doesn't mean that you do that without impunity. And by the way, as many of you know, I'm on the task force for the revision of the JCAH or the JCH guidelines about vasopressor administration by critical care nurses, because I felt it was inappropriate for them to have this kind of tyrannical control over whether or not you were titrating upwards. But I also appreciate that they had a lot of concern because by survey it was really evaluated that nurses were titrating up and up and up and up and up on vasopressors and not actually communicating to the provider that the patient had refractory hypotension, because somewhere in there, perhaps their lives could have been saved if we had introduced something else, like steroids, like angiotensin II, like methylene blue. Instead, we're wasting time titrating up, and titrating up, and not notifying our partners in management. And this is critically and profoundly important. I don't want JCH to be telling me how to titrate, but I also want to be responsible to recognize that when I have tripled my initial dose, I need to notify my provider that my patient isn't responding. So there can be other things added to the therapeutic framework. So this is from T-Blick A and others in the Journal of Clinical Endocrinology. Really, really nice article and a really beautiful distribution here, talking about history, presentation, evaluation, treatment, and follow-up. Pre-existing patients who have already got HPA disease, maybe they're on very low dose steroids, or they have been diagnosed as adrenally insufficient, and now they have a physiologic stress event. They have the flu, they have exacerbation of their diabetes, they have an emotional shock, they have an MI, and they go into adrenal crisis. Adrenal crisis means that they will die without intervention. They're in a crisis. And typically what you see is primary adrenal insufficiency. Cortisol goes down and ACTH goes up. The primary problem being the adrenal gland. Secondary adrenal insufficiency means that the problem is the pituitary gland. So cortisol is down and ACTH is down. So in order to diagnose them, we just draw cortisol and ACTH level. Cortisol down, ACTH level is up. That problem is at the adrenal gland. If cortisol is down and ACTH is down, that problem's at the pituitary gland. But guess what? In either case, the patient needs hydrocortisone. So they're going to get 100 milligram bolus and 200 milligrams IV over a 24-hour period of time. Okay. And then we start a taper and they get followed up by endocrinology. So that's a primary person. If you ever see a band that says, I have adrenal insufficiency, a necklace, the wife or the husband of the patient hands you a card, don't just throw it aside because you're too busy. And it says, I have primary or secondary adrenal insufficiency. The life-saving measure is that patient's got to get hydrocortisone. And sometimes it has to be a much higher dose than this, but this is where we start, okay? If your patient has acute, and that's typically in patients who have septic shock, who are not responding to IV fluids and vasopressors, they basically have a refractory shock, do not do an ACTH test. There is actually rarely a call for an ACTH test anymore. It's flawed, it's not very useful. Just go ahead and give hydrocortisone, 200 milligrams IV 24 hours. You can, and most people like to give 100 milligram bolus first, and then put the patient on 200 milligrams IV over the next 24 hours. Okay, that's the pharmacologic dose. So it's a total of 300 milligrams in the first 24 hours. Now, if they don't respond, in other words, their blood pressure comes up, their glucose comes up, their urine output comes up, their sodium and potassium regulate. If they don't respond, stop after the first 24 hours, right? Don't keep them on cortisol therapy if they don't respond, because they should respond almost immediately if you've done this appropriately. So just like vasopressin, when you add vasopressin, you should be able to titrate down on norepinephrine and epinephrine. If patients aren't responding, why do you keep them on vasopressin? But on steroids, it's much worse to keep patients on steroids if they don't respond. So remember, for that acute patient who is refractory hypotension, right? He has refractory hypotension. You expect that his blood pressure comes up. You expect his glucose to come up. You expect his urine output to come up. When it happens, it's profound, actually. I can't say that I have the experience, probably even 50% of the time, that we give hydrocortisone therapy early enough for you to see the response acutely, but I have seen it a few times where we did it really early, and it's amazing what happens. All of a sudden, you start seeing urine output, glucose comes up, blood pressure comes up, you can titrate down on their vasopressors, and you feel like a real hero. And then we go to the long-term patient, that patient who has prolonged critical illness. And that patient requires mechanical and pharmacologic vital organ support for several weeks. So they're 3 weeks, 4 weeks in the ICU or on your step down area, and they have symptoms and signs that are compatible with adrenal insufficiency. Again, they're on very low dose vasopressor, but you can't get the vasopressor off. You're at 4, you go to 2, they bottom. You go back to 4, they're fine. You go to 2, they bottom. You go back to 4, they're fine. So they're on low dose vasopressors. They're still on the ventilator. Maybe they have some other organ support. We're going to call that critical illness related corticosteroid insufficiency. That's really more chronic, right? Acute is refractory shock. This is longer term. This is a chronic failure of cortisol. And it's very nonspecific, and there's not really any good diagnostic tests. Typically, what you see is that free cortisol and ACTH might be relatively low, but serum cortisol, which is not free cortisol, is typically normal or high. And that's quite a big problem in terms of how you look at your patient, because most places don't do free cortisol evaluation. So again, lots of times you just say, this is what I think. Your doc says, this is what I think. So we're going to start the patient on steroids. They're going to get hydrocortisone 60 in the morning, or 40 in the morning and 20 in the evening. They might get 60, a bolus of 60, and then you go to 40 in the morning and 20 in the evening, and that's substituting what we consider to be the normal release of cortisol from a normal adrenal gland. Once the patient improves, then you will start to taper their dose. But my advice would be, you should always get an endocrine consult once you have considered any of these options, because endocrinology, that's really their gig. So I think a lot of focus today is now on patients who are longer in the ICU on really low dose vasopressors, who continue to fail a spontaneous breathing trial. They continue to require mechanical ventilations. So again, the low plasma ACTH and a low free cortisol, most hospitals don't measure that. We don't measure that. And they have some other kinds of things. So first of all, eosinophilia, which is a major sign associated with corticosteroid deficiency. And unexplained need. Your sepsis is resolved. You don't have cardiogenic shock. I just can't get you off of vasopressors. So you think back in your history of those patients who were day 14, day 18, where they're on 4 of norepinephrine, you titrate to 3, and their pressure drops a little, and you go to 2, and they bottom out, you got to go back to 4. It's not excessive vasopressors typically, it's low-dose vasopressors. They may also have delirium, they may have encephalopathy. If they can tell you they're tired, they will, but most of them, they're still intubated. So you're not able to get them off. And again, you're going to look at that hyponatremia and hyperkalemia, and something else that you can see with this, with corticosteroid deficiency, is hypercalcemia. So we're going to think about all of these issues, and just remember that this is common to see in patients who have had several weeks in critical care or critical illness or acute care. So they could be on your step down areas. There are some other things for us to think about. That is, opioids interfere with the HPA axis. If you've been giving glucocorticoids, of course, that's going to affect the HPA axis, and some other things like rifampin or phenytoin, so dilantin or etomidate. Normally, you're not giving that, but you certainly may be giving rifampin, dilantin, or opioids, and those may also induce more this corticosteroid chronic insufficiency. So we really need to be thinking about that as we look at our patients. So now we go back to case 1, right? Remember, we looked at her before. She was unresponsive and acute shock. She was hypotensive with tachycardia. She had had surgery with an extensive upper pole renal cell carcinoma. She's got hyponatremia and hyperkalemia and a low glucose. But when we look at her 3-month history, it looks like she may have had adrenal insufficiency because she had a decrease in her appetite. She was lethargic. She had fatigue. She had a lot of subtle complaints. She actually looks like she has adrenal insufficiency. So we think this is probably pre-existing. On her ICU admission, her plasma total cortisol was low, 3 micrograms per deciliter, 82.8 nanomoles per liter. Those are the measurements, which would be, this is what we look at normally, and we look at micrograms per deciliter. This is your normal. So she's just a little bit low, and her ACTH was substantially elevated. So what that tells you is her pituitary gland is working fine. She has a primary adrenal insufficiency, and she had adrenal insufficiency before she came to us. So we believe this is pre-existing and that it's primary. It's the adrenal hormone, not the pituitary hormone. That's called a primary disorder. But remember, doesn't really matter. She needs to get hydrocortisone. So she gets an initial bolus of 100 and then 50 milligrams of hydrocortisone every 6 hours for 24 hours. Almost immediately, her shock reversed. Her electrolyte imbalance improved within 12 hours. 24 hours later, she wakes up, she's extubated. After she's extubated, she now becomes hypertensive because now she's getting too much steroid. So now we reduce her steroids. But within 24 hours, her shock is reversed. She wakes up and she's extubated. Okay. Case number 2, remember the 55-year-old man who came in with respiratory distress. He has septic shock because of community-acquired pneumonia. He has a very high-grade fever, hemodynamically unstable, goes to the ICUs, intubated, very hypotensive, very high-dose vasopressor. He's like on 60 of norepinephrine and 12 of epinephrine. He's gotten 4 liters of fluid. What do you think? Is this pre-existing, acute, or chronic? Well, he just came. So we're going to say that this is acute, correct? So we're going to give him 200 milligrams of hydrocortisone per day. You could give him a 100 milligram bolus, but as you initiate that 200 milligrams of IV per day, remember, divide into 4 doses, divide into 6 doses, whatever you want to do, or giving him a continuous drip. His blood pressure gradually increases, but because it's acute, he doesn't have quite the compensation as the pre-existing patient, so it takes a little longer for him to improve. So over the next 72 hours, the dosing of vasopressors tapered from 50 and 12 down to 4 and off. And over the following 3 days, he was weaned off from his respiratory support and all vasopressors, and the hydrocortisone treatment was tapered and discontinued. So we think that patient is acute. And then the last patient, prolonged is the key word here, prolonged critically ill 67-year-old male who initially is admitted to ICU for abdominal sepsis, right? And he's had multiple redo laps with an open abdomen. He's still in the ICU on day 30. He's encephalopathic, and dependent on vasopressors, mechanical ventilation, renal replacement. He's a chronic patient. He's a chronic renal insufficient patient. Now, he was getting a lot of opioids for wound care. He also had moderate hypercalcemia, hyperbilirubinemia, and high plasma bile concentrations. Those are important, but not going to be the key things that we're looking at, except for that hypercalcemia. His plasma total cortisol was high, but remember, that's not free cortisol. And on day 30, his plasma cortisol had come down, which meant also that the serum free was probably quite low. But what we now understand about chronic patients is that they may have an adequate level of circulating cortisol, but it is the ability to transport and release that cortisol that actually impacts the chronic patient. So he has low low proteins that bind with the cortisol. And since they don't bind with cortisol, that really can profoundly affect their capability. This is a chronic patient. Okay, so he gets the chronic treatment, which is 40 of hydrocortisone in the morning and 20 in the evening. And once that was started, vasopressors were pretty swiftly tapered and stopped. Now, remember, he was on low dose vasopressor. So now we're just able to go from 4 to 3 to 2 to off. His urine output increases, his serum calcium concentrations normalize, and he regains consciousness. And that's the chronic patient. So Dr. Jay Farkas, who is pulmonary critical care at Vanderbilt, put forth this kind of diagram for just considering what we want to do, right? If your patient has vasopressor-dependent septic shock, and that means really first 12 to 24 hours, strong indications for steroids, you gave them fluid and they're on vasopressors, strongly consider steroids. Of course, if they've been taking steroids or they have chronic adrenal insufficiency, you should give steroids. Things that make you say, I'm not going to give steroids right now, right? Patient is on a paralytic. Well, he's going to be adrenally insufficient at the cellular level because that blocks the uptake. He has DKA. If you give him steroids, he's going to become more hyperglycemic and more ketotic. So you've got to be very, very careful. Now, you might give him steroids, but you'd never do that if the patient had DKA unless you had a continuous insulin drip and you were adjusting insulin appropriately for his ketosis. If he has HIV, TB, HPV, or any kind of invasive fungal infection, probably going to avoid steroids. Recently had surgery and you're having problems with his wound healing, you're probably going to avoid steroids. And if he has active or recent peptic ulcer disease and GI bleeding, probably avoid steroids. So that's pretty straightforward. There is no absolute answer, my friends. Unfortunately, no absolute answer. How sick is your patient? And are they responding to treatment? That's really what's important. And then you say, okay, they're really sick and I'm titrating up on his vasopressors and I'm doing it aggressively. Probably need to start steroids, okay? If your patient has aortic stenosis, cardiomyopathy, they have severe pulmonary hypertension, those are pre-existing disorders before they came to you, they already have used their reservoir for survival, they are probably going to need steroids. But in the end, my friends, it's almost always a clinical decision. So I want to remind you, there are some very important key points from the evidence that you want to appreciate so that you know how to talk. That the failure is in the affinity and or the binding of cortisol. So the affinity at the cellular level or the binding of the cortisol to circulating proteins. That stress dose steroids, that's this very low dose, 200 to 300 milligrams per day. They do not seem to reduce mortality, but they do reduce the duration of septic shock. So as long as you're paying attention to everything else that's going wrong, you may be able to improve survival. They do not increase the risk of superinfection. So that is not a reason to withhold steroids in patients who are hemodynamically unstable. And by the way, stress dose steroids are not only a benefit to the hemodynamically unstable patient, but to the relative hypoglycemic patient and to the imbalanced electrolyte patient, as I discussed before. So I think we already talked about those issues. We're just going to, well, we may not have actually looked at that patient on day 30, that patient day 30 who remained encephalopathic and it was dependent on vasopressors. He got steroids, remember? And remember, his problem was really related to his plasma carrier proteins. Now, unless you're in a research trial, you're not looking at that. So again, this is all really based on your clinical judgment, the discussion you're having at the bedside about how the patient has failure to thrive, and you just can't get them off of vasopressors. They may have chronic adrenal insufficiency that is related to their critical illness. So everyone deserves a trial with steroids when you can't wean them off their vasopressors or when they cannot pass a spontaneous breathing trial. You should always have a discussion about whether or not they need steroids. The two primary large multi-center studies are the Corticus trial and the Didier-Anane trial. And Didier-Anane has had 3 trials. The last one was in 2021. Anane says steroids are fantastic. They improve survival. They reduce duration of septic shock. In Corticus, they said steroids are basically worthless. They don't really improve mortality, but there's a lot of difference between the way patients were recruited in these studies. The raw data for both of those studies, when you look at the raw data, it's somewhere in the middle, which means we don't really have an answer. We still don't have an answer about whether we should give adrenal support in critical illness. But I think every patient deserves a discussion. And what that means is when you see any one or all of those three, but most importantly, refractory hypotension, relative hypoglycemia, imbalance, opposite imbalance, meaning potassium is down and sodium is up, or sodium is down and potassium is up. And that's actually what it is sodium is down and potassium is up. You should always think of the possibility of adrenal insufficiency. Every patient deserves the discussion. Once you've done your due diligence, you may not be able to further impact anything, but if you're not doing your due diligence, then I see that personally as a failure at the bedside of very excellent critical care nurses who are always trying to do the right thing. I thank you very much for joining, and I hope to see you soon. Tomorrow we'll be doing a case review on a critical patient in the CV ICU. Thank you so much. See you next time.